You're listening to The Q Switch with your host, Spence.
Welcome, one and all, to the Q Switch Conversations podcast. I'm your host, Spence, and the mission of this show is to tackle relevant subjects currently impacting ophthalmology and pull in leading eye care professionals and industry players to discuss their unique perspectives. So let's jump right into it. Today, we're focusing on a topic that touches millions of patients, yet often goes unappreciated until it becomes truly life-altering, and that's ocular surface disease. From dry eye to corneal disorders, the health of the ocular surface plays a critical role not only in how well we see, but also in how comfortable and confident we feel in our everyday lives. Advances in diagnosis and treatment are changing the way we care for patients and those outcomes. And there's no one better to help us unpack this subject than our guest today, Dr. Priscilla Fowler. Dr. Fowler is a fellowship-trained cornea specialist, founding partner at TriaVision in Hoover, Alabama, and an expert in the full spectrum of contemporary corneal procedures. She also is a strong advocate for innovative treatments like Prokera amniotic membrane and has built a career dedicated to restoring vision and improving quality of life for her patients. Dr. Fowler, welcome to the show. It's such a pleasure to have you on today.
Thank you so much. It's great to be here. I appreciate the invitation.
Well, good. Hey, so before we get into today's topic, I wanted to pause for a moment and have you share a little bit about TriaVision, because as far as I can remember, Callahan Eye Foundation has been the end-all be-all for all things eye care in the state of Alabama.
Oh, sure, certainly. So a group of us who had been at Callahan for a long time had this vision to start a multi-specialty group outside of Callahan to really tailor our services and make a more personalized approach to medicine while maintaining the most advanced treatments that we could offer patients. So we are now the largest private multi-specialty group in northern Alabama and still working to expand. But my partners and I have worked together for a long time. We all have been in academic medicine and really appreciate that experience, because we kind of honed our skills on some of the toughest cases that could present. And we want to take that expertise out into the community to provide that both medically and surgically.
And so when did you and your partners decide to, really split off and make this real thing instead of just talking about it, actually putting action behind it and, breaking ground and acquiring practice, or however you did it? When did that happen?
I think it was an evolution over a couple of years, but we opened almost exactly a year ago. It was July 1st of 2024. So we just had our 1-year anniversary.
Wait a second. Hold on. A year ago, but you have like 12 sites or 11 sites. How did you explode like that in 1 year? That's unheard of. That's like microwave practice. How did that happen?
There's such a large group of us. We all had pretty fully developed practices already. And when we opened, I think we opened with 10 locations.
Oh, wow. Okay.
And some of the locations were in the same spot, and some of them were nearby our old locations. But we sort of just hit the ground running right away with many locations because we needed a place to continue our practices and see all of our patients. So it's a little different than moving to a new place and starting a practice de novo.
Mm-hmm. So you say it's multi-specialty. What specialties does TriaVision support?
We have glaucoma, cornea, obviously, comprehensive. We have full spectrum optometry with contact lens department. We now offer pediatric services. We have a pediatric optometrist. So we do not have neuro-ophthalmology currently, but we have close ties with the specialties that we don't serve.
Okay, well, thanks for sharing the TriaVision story. I wish you and your colleagues continued success.
Thank you.
So let's turn to why you joined the Q Switch today, and that's to discuss ocular surface disease. To kick things off, what drew you to cornea ocular surface disease as a focus within ophthalmology?
Sure. Well, naturally, as a cornea specialist, we get a lot of training in ocular surface disease. I think my interest really stemmed back around 2015. We were starting to do some laser-assisted cataract surgery and more premium lens options for patients. And as I was searching for those patients, I noticed that many of them had poor quality measurements. And it made it difficult to determine what our corrections were going to be. And it also made it uncertain their visual outcomes after surgery, because we see patients all the time. I get referred in my cornea clinic, the unhappy cataract patient, someone who had cataract surgery somewhere and their vision quality after cataract surgery isn't good. They're unhappy with that and they want to know why. And 9 times out of 10, it's because of the ocular surface. So I found myself being really frustrated by that. And although we did have some good treatments at the time, things were starting to explode in the world of ocular surface because others were noticing this too. So suddenly we had all these diagnostics where we could detect inflammation on the surface. We could look at the quality of the tear film with interferometry. There are many things that were kind of new, and people were really starting to focus on dry eye and how it was affecting their outcomes from cataract surgery, but just vision in general. And there wasn't really anybody in Alabama focused on doing that. And so that's what kind of got me started on it. And then once you open the door and start treating dry eye patients and having some success with them, the people just start flooding in because there aren't many doctors who really have a strong interest in dry eye, and it's difficult to treat. It takes a lot of time, a lot of hand-holding of patients, and really you have to have an algorithm to be efficient with it so that it doesn't just totally overtake your practice.
Well,
Um,
that's a great lead in because, since dry eye is one of the most common yet often misunderstood conditions you treat, let's go and start there. How do you explain to patients in simple terms what dry eye really is and why it happens?
yeah, and that's a tough one because it is multifactorial.
Hmm.
Patients are often coming in wanting to have one answer, like, why do I have this? And I'm like,
Right.
well, it's a combination of things. It's your age, it's hormones, it's medicines you take, it's contact lens wear that you've had for since you were a teenager. It's how you use your eyes, screen time. The increase in
Oh,
screen time over the last 15 years or so, we see dry eye disease in younger and younger people because they spend a lot of time on screens. And so there's really not one specific thing we can point to.
hmm.
One thing that I still to this day have to impress upon patients is it's not something I can cure. It's kind of something that's developing and progressing over time. We do better if we detect it early to get it at least under some control so it doesn't progress. So it is a progressive condition. And so I kind of compare it to taking care of your teeth.
Hmm.
You have to brush and floss your teeth to keep healthy teeth. You need to take care of your eyes and use your tears or the medicines that I prescribe to keep your eyes healthy and happy so that you have good vision and comfort for the rest of your life. And that usually resonates with people when they think of it that way.
So many people dismiss dry eye as just an irritation, but it can be quite debilitating. Can you talk about how untreated dry eye impacts quality of life, both physically and emotionally?
Yes, absolutely. That's a great question. I think patients start out with minor irritation, but as it progresses, it can go further than that into painful conditions. Certainly, poor quality of vision that fluctuates a lot for people who do have to work at computers or have heavy reading or just like to read in general. It makes it difficult for them to do those tasks for a long period of
Hmm.
time with good comfort and good vision. And I think over time, the longer it goes on and the longer it's untreated, it does take an emotional toll for people because they're not able to do the things they enjoy with any sort of longevity. And so they come in very frustrated also, often because they bounced around to many different providers and just really haven't gotten a lot of relief. And it's often just they've tried a bunch of things, but maybe just not in the correct combination or for long enough. They haven't been patient enough with the treatments.
Sure. And every patient pretty much has their own prescription. No, there's no one, as they say, silver bullet to cure every, if you have 10 patients, you'll probably have 10 different treatment plans for those folks. Does that sound about right?
Absolutely. That's absolutely correct. And I tell patients, new ones, when they come in and they've seen different people, I tell them we're going to try some things that maybe you've tried before, but maybe not in the same combination.
Hmm.
But we have to do some trial and error to get to what's going to get you feeling better. And it takes a long time. It's not a quick fix. And that's another thing that patients are sort of unaware of. And actually, I was unaware of when I first started doing this. I didn't really realize how long it would take in some patients. But in some patients, it can take 2 or 3 years before you get them to the point where they come
Wow.
back and they finally say, yeah, I really don't feel my eyes that much anymore. And it just took us that long to get to a place where they feel that good. It's just the drugs that we have are good drugs,
Hmm.
but they take time. We're on the order of at least 3 to 6 months, but maybe longer. And that is something that's hard for patients to understand at first. And even
Yes.
physicians. Yeah.
Yeah, setting those expectations, especially when they're going to be an extended period of time, that 6, 9, 12 months, as you mentioned, 3 years, that's a long time because I'm sure they walked in thinking, oh, they'll give me some drops, 2 weeks, 10 days, I'm good. And all of a
Yeah.
sudden you shock them with, you know what, this is going to be a while.
Yeah. Yep. Yep.
So once patients understand the seriousness, the next step is often education. What are some of the most effective ways you educate patients about maintaining ocular surface health and preventing worsening dry eye?
We have lots of handouts, of course. And I think early on, a little bit of frequency of visits so they kind of get the same information each time. Even if it's not from me, they get it from one of my technicians. So we kind of repeat, it's very repetitive, and they hear the same information multiple times. And over time, and I also have to tell them, every single day, you may not do all of these things I'm asking you to do, but it's the consistency that you have over the next 5 years with it, where you continue to some degree on a weekly basis, this stuff, that's what's going to get you where you want to be. And that also lets patients off the hook a little bit so they don't feel like overwhelmed every single day with having to do every single thing we ask them to do. But we have handouts, and they become familiar with those handouts where they recognize it because they've looked at it so many times. And we just have to keep educating them, and we have our staff trained to talk to them about it too.
I'd imagine one of the biggest challenges is, much like any drop regimen, whether it's post-op or glaucoma, is patient compliance. And so to really impress upon the patient how involved they have to be in their own therapy, their own care, their own outcomes has got to be absolutely critical. And I think, like you mentioned, your staff and you and people surrounding the patient when they're in the office, that they understand, at least try to communicate to them how important that is.
Yeah, they definitely need that support. Some of the newer diagnostic testing where I can show them their inflammation is getting better, like I can show them that there's been improvement. Anytime I can show them something that's gotten better, that's helpful as well because they feel like their efforts are paying off.
Sure.
So we try to really encourage, and we have to be their cheerleaders to keep them doing it. And we also have to get them some results. And so being very aggressive with some of these more severe dry eye patients to get some results early on, just so they feel a little bit better, so they begin to believe that it's possible for this to get better. That's important too. And I think that's where sometimes other physicians fail because they're not being aggressive enough because they're just not sure about it. But patients don't trust them anymore because they're not feeling better or even
Right.
a little bit better. And that's sort of something I learned over time, just doing it, just develop these protocols, and with experience, you change and grow. And then you kind of learn from the tough cases, right? And just get better at it.
So how critical is ocular surface health in the success of procedures like cataract or refractive surgery, which you perform regularly? And I think you spoke to it earlier, but maybe more specific to that question, what do you have to say on that?
It's really critical. The quality of vision after cataract surgery is not good if the ocular surface is poor. This is especially true with some of our premium lens implants, especially the true multifocal lens implants. If you have even a little bit of dryness, the quality of vision goes down sharply, and patients notice it, and they're very unhappy. And they're especially very unhappy if they've paid a lot of money to have great quality vision and it's just not there. So in my population of patients that are the dry patients, I tend to not use true multifocals in those patients. I do some
Oh,
other modality because there's a high risk of them being unhappy in the lens. But there are other modalities to give them some freedom from glasses. Some of the extended depth of focus lenses, some of the lenses that don't split light as much are a little more forgiving for pathology, dry eye disease, macular disease, other things. You can still do those lenses. But, if you can get a better ocular surface, you have a wider variety of things you can offer patients. And I think
do you end up tackling or at least approaching the dry eye question well ahead of the surgery? Don't let it to be something you deal with afterwards.
absolutely
Sounds like that's your approach, you and your team, that's your protocol?
try to treat it ahead of the surgery and certainly diagnose it ahead of the surgery because there is a little bump where dry eye will get worse right after surgery just from
Hmm.
incisions, we think, disruption of the corneal nerves. And you don't want the patient blaming your surgery for their dry eye disease. But now that we've got some newer treatments that work a little bit faster, we can work on that surface for a month or 2 months, get better measurements, so that they can have those outcomes that they're looking for.
Now, there's the cataract side and there's a refractive side. Do you treat those patients differently in terms of addressing their dry eye? Because obviously, LASIK and those type of procedures are on the surface of the cornea and are probably a little more impact, of the surgery and the outcomes.
Those patients definitely get more dry eye than other patients due to that disruption of the corneal nerves, especially LASIK surgery where you're creating that flap. I think most refractive surgeons will treat dry eye ahead of time and even start them on a prescription medicine like a cyclosporin or lifitegrast before they do their surgery and maintain that afterwards just to try to reduce the dry eye symptoms. And I would say most patients get better with attention. It's when you ignore it that you can get into trouble.
So beyond education, patients often want to know what new treatments are available. What recent breakthroughs or advances in dry eye treatment have you found most exciting or most beneficial for your patient?
I think one of the most exciting things, are amniotic membrane treatments that we use in combination with drugs to speed up the process of getting these patients better. You remember earlier in the podcast, I said it takes a long time. That's probably the most frustrating part of dry eye therapy. One thing we can do to move that needle a little bit faster is to treat these patients with amniotic membrane. That treatment doesn't work alone. It needs treatment with a drug along with it, but that just moves the patient down that pathway of improvement a lot faster. So that's something relatively new that now is something that is a covered service for patients with dry eye disease.
Oh, okay.
Especially if they have decreased sensation related to their dry eye disease, which many dry eye patients do. So we can treat that patient with amniotic membrane therapy for a week, 2 to 5 days. It improves the surface staining, which improves vision immediately for those that have decreased vision. It improves comfort for those who have a lot of discomfort or even pain. And it even continues to show improvement after it's been taken off, especially if we make sure that we've got them on an anti-inflammatory therapy for dry eye, like a cyclosporin or a Xiidra. And there's even newer agents. There's Vivi and some others that are coming. So we have a lot of new drugs in development as well that we can offer patients to try.
So we're going to get into the amniotic membrane. I think it's Prokera, I believe the name is, in just a moment. But before I do, a couple more questions on dry eye. Are there any myths or misconceptions about dry eye that you find yourself frequently having to correct with patients?
I think the main one is that nothing's going to work. I already tried everything, Dr. Fowler, and I don't think you can tell me anything new that's going to work. Either that is a misconception that people come in with because they're frustrated. I think other physicians will probably, I hear that from other ophthalmologists who don't treat a lot of dry eye, maybe comprehensive ophthalmologists who say, I just haven't found any of these things to work, that none of these treatments really get patients better. So that's probably the most common misconception I see, and that's just simply not true. We have a lot of success with patients, but it does take a lot of effort. I think the other common misconception, or the common thing that people don't understand, is that even though we have things that work, it's not curable. So we can't treat this and then you're done and you never have to maintain what we're doing. But I try to assure patients that you will have to work very hard in the beginning, but as we get better, you'll be able to back off and not have to work as hard once you become healthier.
So, of course, dry eye is only one piece of a larger ocular surface puzzle. Outside of dry eye, what are some of the more common ocular surface diseases you encounter, and how do they typically present in your clinic?
I think, dry eye disease has a big umbrella of things that are under it, and people often forget to look at the lids. A lot of times people have blepharitis. This is extremely common. They have meibomian gland dysfunction, so they're not producing enough oil for their tears. And these things, if they're not detected and you don't treat those parts of the problem, then your dry eye therapy is not going to help that much because you have this underlying thing that's making it worse. So that is a common problem. We have more serious things that we see that result from dry eye disease, corneal ulcers, infectious keratitis. We see lots of patients with viral keratitis that is certainly made worse if ocular surface disease is bad. Neurotrophic keratitis, we see that a lot from viral conditions and other conditions that cause the corneal surface to break down. And this is where the corneal nerves are no longer sensitive and they can't tell the surface to remain healed, so corneas break down. And in the setting of a bad ocular surface, it can be a disaster. And so these things just kind of compound upon each other.
Yeah, they make things worse. So when you see patients with corneal or ocular surface disease, what are some of the first line strategies or tools you typically reach for before escalating into advanced therapies?
I think, like I said, treating the lids and trying to get more oil into the tears. So we'll do things like warm compresses. We'll do some lid cleaning with either lid wipes or sometimes antibiotic ointment to try to clean up the lids. Sometimes we'll use oral antibiotics to help the lids and make those oil gland secretions healthier. Artificial tears are still in our toolkit. I prefer tears that contain more of the oily component of the
Okay.
tear. I think they have more staying power and give the patients more comfort. There's a recent one that is a prescription called Mibo that's getting a lot of buzz right now. Patients really are liking that, and that's basically replacing the oily layer of the tear film. So it's not really a medicine that's treating anything per se, but it's just putting some oil back into the tears so we don't evaporate those tears off the surface so quickly. So we reach for those things almost immediately. If there are signs of inflammation in the tear film, which we can see, or we're able to pick it up with a point of care test, then we immediately reach for one of the anti-inflammatory therapies. Currently, there are 4 that are on the market. And if I'm being honest, we usually have to reach for the one that the patient's insurance will cover. They all work and they're all good. Some of them work faster than others, but it's often dictated by what's covered because the drugs are very expensive.
I see.
They're not covered. From there are some other newer therapies that increase tear production by stimulating the corneal nerves. So there's one that's a nasal spray called Tervia, and then there's a similar one that is the same thing in a drop form called Tripteer that just was released. So we're getting some experience with these newer therapies and having some success there. And again, if those are covered, I will usually try one of these new things in patients who have tried other things and maybe they feel that they failed or they state that they can't tolerate these medicines, which patients will often say, well, let's try this other one and see if you like it better. So it's nice to have all of these tools in our toolkit. We have a lot of things that we can try to give patients comfort. And oftentimes it requires multiple therapies at once, which can be a little bit of a trick to get covered for patients. But when we can do it, if we can use like one of the nerve stimulants with one of the anti-inflammatories, with the oil-based tear, like all of those things together at once are what gets that patient kind of over the finish line where they start feeling better.
Mhm. So, I mean, you dripped off easily 10, 12 different medications that do different stuff. And I think if I was a patient coming to see you, and the fact that you kind of have a whole armamentarium of combinations of things and you're well informed as a provider gives me more options and allows me to kind of believe again that there's a solution out there that someone else may not have tried or put together because, again, you were dialed into the latest technologies, therapies, medicines that I think, in different combinations for different people can get them, as you said, across the finish line.
Yeah, no, absolutely. And, it helps that we've had success stories. So I can share that with patients, say, look, we've had people who have bad dry eye that's as bad as yours, that we've managed to get them feeling better. It's taken us some time, but I know it's possible and I want you to have hope, and that's really what they want to hear, that there is hope that they will feel better. Not take these tears. There's not much I can do. So
Yeah.
that's what they sometimes hear. Yeah.
So I think that should bring us to Prokera, which you've been a strong advocate for. For
Yes.
listeners who may not be familiar, can you explain what Prokera is and how it works as a treatment?
So Prokera and Cam 360 is the newest version of it. That is amniotic membrane that has been cryopreserved and created so that we can use it clinically as an outpatient. It was first used, I believe, in burn patients for wound healing, like large sheets of it. And then we were able to use it in the operating room for the eye. And it has these amazing healing properties. Very strong anti-inflammatory properties, properties to reduce scarring, wound healing properties, properties that promote nerve regeneration. So very strong healing properties for the surface for any surface and any wound, but particularly the eye. Prokera, they created it on a ring so you could place it in the eye like a large contact lens. It is cryopreserved, frozen, but it's wet once it thaws out. It maintains some of the anti-inflammatory properties with the way it's preserved. So I do think that it has stronger healing properties than some of the freeze-dried versions of amniotic membrane. The newer version, CAM 360, has kind of expanded who we can use it in because it's a smaller piece of amniotic membrane that can be placed either under a bandaged contact lens or a collagen shield. So this makes it available for patients who've had glaucoma surgery. Maybe they have a tube shunt or a bleb,
Hmm.
and the Prokera wouldn't fit there or could be damaging to the bleb. So it's now expanded the population that we could use it in. I think the other reason that we can use it in more patients is it's now indicated for patients with mild decrease in corneal sensation.
Oh, wow. Okay.
That includes many, many dry eye patients. So I first used it way back in 2015. I had a patient that had severe pain, maybe almost to the point of a corneal defect. She had decreased vision that was down to the 2200 level on the eye chart, and she hadn't been driving, and it had been quite some time. And this was all due to ocular surface disease. She had Sjogren's syndrome. And we used Prokera in her really just to help her with her pain. But what we noticed the minute we took it off, that her vision improved back to 2020, and she started crying
Oh,
because she
wow.
said, I have not been able to see because my dry has been so bad. I can't drive. It's affecting my life. And I was like, wow, this is really good stuff. Like this improved her vision, like, all the way to 2020 in such a short period of time. And of course, that's not maintained unless you're treating the patient with something else. You need all the other therapies to go along with it. At the time, we didn't have as many indications that the Prokera was covered for, so we couldn't use it as much. So being able to use it now in these dry eye disease patients, I knew it was effective. I just was a little bit handcuffed and unable to use it just because of billing purposes. Really, we want
Sure.
to make sure it's covered for the patient. So that's really taken off for us, and we've been able to help a lot more patients and just speed up the process of their improvement.
You mentioned a moment ago that there are some alternatives. What makes Prokera stand out to you as a treatment option compared to other therapies available today?
I have used the other therapies. I think the fact that it is cryopreserved and it's hydrated and wet I think that has a lot to do with how effective it is. Also, the molecular properties of it, some of the anti-inflammatory properties are not preserved when it treated in a different way and freeze dried. They just not maintain the same anti-inflammatory properties. So I don't think it is as strong of a treatment when it's freeze dried versus the cryopreserved.
So you've been using it since 2015, and you said that the indications have expanded. Are there specific scenarios, patient types, or disease presentations where you find Prokera especially effective, or where it's an absolute home run? It's no question that's a Prokera patient.
Yeah, absolutely. I mean, any patient that comes in with a corneal epithelial defect, whether it's from an abrasion, from recurrent erosion syndrome, that's a home run. I think even the HSV keratitis patients that have a defect, a dendritic keratitis, I think it helps those patients tremendously. Reduce the scarring in those patients. We use it in corneal ulcers, bacterial corneal ulcers, when we're starting to get some resolution of the ulcer, and now we're trying to get re-epithelialization of the cornea so that it heals. I think it helps those patients and reduces inflammation, so it's a home run there. And it's a home run in the dry eye disease patients. If we can show that there's decreased sensitivity and place that, pretty much everyone comes back saying, I feel better, I see better. And I'm like, okay, so now we have to maintain this with everything else we're doing. So I think in all of those cases, it's a home run.
So, um, obviously, you have your practice, and uh, how widespread is the uptake of Prokera in some of these patients that you use it for? Is it now like a movement? Is it a thing, or is it kind of your own kind of approach to treating these patients?
That's a great question. I think locally, we're one of the few practices doing it right now. We've probably had it for The newer version, the Cam 360, the smaller version, we probably had for 6 months. Prokera has been around a lot longer, obviously. And I know some of the other specialists use it for the more severe corneal diseases. For dry eye disease, I think there's less uptake there. You do have to test corneal sensation on every single dry eye patient, so you know if their sensation is down and if they're eligible for the treatment. So that's something you have to incorporate into your practice, which is a bit of a change in practice pattern, even for us when we first started doing it. So I think it hasn't caught on. I have heard some say that they don't believe that it works, but I think if you see it in action enough times, you'll be a believer.
So when you introduce Prokera as a viable option for a particular patient, how do they typically respond when you recommend it? And are they hesitant, curious, or generally receptive once you explain its benefits?
I think in my practice, because most of the patients have advanced dry eye disease, they are extremely receptive and they are extremely excited to have something new that has been shown to work, that I've seen work in other patients. So I really haven't seen people be very skeptical. They want to try it. And that's what I've seen anytime something new has come along in the last few years. Most patients are willing to try anything that might advance them further than where they already are. Even if they're feeling better, they're like, yeah, if this makes me healthier and will help me maintain this improvement that I've got, they're all for it.
Mm-hmm, mm-hmm. So as we look into the future, it's clear that the conversation around dry eye and ocular surface disease is only going to grow and expand. Where do you see the biggest opportunities in improving dry eye care and ocular surface health in the next 5 to 10 years?
I think the biggest opportunity is for more doctors to start using these technologies. I agree with you. We are going to see an explosion of it because we've got an aging population on our hands, and it is a disease of aging. Even though we are seeing it in younger folks with screen time, it's definitely something that gets worse with birthdays. That's what I always tell patients. So I think as more doctors start using these technologies, the drugs and amniotic membrane and other things as they come along, I think that's our biggest opportunity. And there's so many of these patients. We need more help taking care of them. But they are, if you are practicing ophthalmology, they are walking through your doors. So you have an opportunity.
Well, when I started at Alcon back in 2011, there were just a small handful of doctors throughout my service area that were even focusing on dry eye.
Mhm.
And that was again 2011. You jumped in 2015 with Prokera and some other things, but you've obviously been focusing on it for a very, very long time. And I think that a lot more people are going to follow your lead in up to now, and I think into the future, both on the optometric side as well as the ophthalmic side.
Yeah, I hope so.
Yeah. So Dr. Fowler, thank you so much for joining us today and sharing your insights into ocular surface disease, the impact of dry eye, and the innovative ways you're helping patients find relief and restoration. Your passion for patient education and your dedication to advancing cornea eye care really shines through. To our audience, we hope today's conversation gave you a deeper understanding of how important the ocular surface is, not just for vision, but for overall quality of life, whether you're a physician, a student, or simply someone who's experienced the frustration of dry eye. There's never been a more exciting time to follow the breakthroughs happening in this field. Dr. Fowler, before we close, if anyone wanted to reach out and contact you based on this episode or visit TriaVision, what's the best way to contact you?
Probably the best way to contact me is by email. So I can be reached at pfowler@triavision.com.
Thanks a lot, Dr. Fowler. So as always, we'd like to thank Riverside FM and Passionate Media for making this show happen, and Meridian Medical for making it all possible. That's a wrap for this episode of the Q Switch Conversations podcast. Until next time, this is Spence, and I'm out.
You're listening to The Q Switch with your host, Spence.